TRT, which stands for testosterone replacement therapy, is a term often thrown around loosely in fitness circles. But what is it and what differentiates it from anabolic steroid abuse? In this episode, I'm joined by Dr. Ed Davila, who is not only a physician, but also a bodybuilder. Welcome to another episode of the Dr. G-Fit YouTube channel. Today I have with me a very special guest and a good friend of mine, Dr. Ed. I can't wait to hear all of your information here that you're about to tell us. I think we have some cool things that we're going to talk about. So Dr. Ed Davila and and I'll let him introduce himself here in a little bit, but we met a couple of years ago at a conference for the International Society of Sports Nutrition, and we've collaborated on a couple of projects. He sits with me as a scientific advisor for the National Academy of Sports Medicine. He came on board this year, and we're just continuing to kind of do some projects together. We have a lot of similar passions. But Dr. Davila, why don't you go ahead and tell us a little bit about yourself and your background, because I love your background and your story.
Appreciate it, Dr. Escalante. So, bumper sticker about me. From a small farm town in South Texas, raised there my whole life, and went to Baylor University, got my bachelor's in biology. Always knew I wanted to have some time in the military, wanted to be able to serve the U.S. Armed Forces, but I made a promise to the family, education first, got my education, and immediately after that, headed off to the Navy. I served as a naval officer for 5 years, did what's called information warfare, ranging from submarine operations to overseas, just doing little fun things here and there. But the interesting thing was my interests have always been in the realm of exercise, sports science, and functional performance medicine. While active duty, I actually had the privilege to be able to spearhead a lot of projects looking to develop exercise protocols, fitness facilities, both for in-country and downrange. After I got out of the military and wanted to continue pursuing my career in this world, so I went back to Baylor University and pursued my master's in exercise physiology under Dr. Darren Willoughby. And under his advisorship and mentorship, he's like, there's a huge necessity for people like us who absolutely not only respect but understand the power of this kind of field in the clinical practice. So you should pursue the aspect of taking it into medicine. And I did. So went to med school, and now I'm currently a doctor of internal medicine.
That's awesome. That's awesome. Yeah, I really like your diverse background, because I mean you have your traditional in biology, but you have that master's in exercise science and physiology, which really kind of gives you an understanding for how the body functions in terms under exercise conditions, and the nutritional interventions and everything, which I think really as a physician, I think really gives you, I think really an inside lane, an inside track, because obviously today in society we see a lot of obesity, metabolic syndrome, diabetes, etc., right? So we all know through the American College of Sports Medicine actually broadcasts this very broadly, which is exercise is medicine, right? And I think one of the issues that we have in today's society is that a lot of doctors say exercise is medicine, but they don't know how to prescribe exercise, and they don't know how to prescribe nutrition, because that's a very small part of any part of your medical training, because you have to learn some of these other things. So can you talk
100%.
about that a
You
little
can
bit?
cram the entire education of nutrition and exercise science in medicine in probably a weekend. And not to say I'm not trying to say it to bash, I'm saying that to give context that you're right. A lot of individuals try to go to their clinicians to try to achieve this information because it makes sense to do so. But in reality, a lot of that education is not there. So it's a very, very minimal amount of detail that the general clinician is able to provide in order to be able to craft something more specific and nuanced. And not just looking at things in terms of the generalization of health, but looking into what most people actually want is I want to feel better. I want to perform better. I want to exist in the world at a level which allows me to enjoy life, not just I'm normal or I'm healthy.
Absolutely. The slogan that I like to say is, we don't exercise to add life to our years, or years to our life, we had to add life to our years, right?
100%.
And that's really what it's about. What you're saying is that vitality, which brings up really to the main subject of today that you and I talked about discussing, which is testosterone replacement therapy, hormone replacement therapy, TRT. I think that's something that is thrown around a lot, and it's a very sexy term in a lot of ways, but I think it's often misunderstood. I hear a lot of bros in the gym saying, I'm just on TRT, bro, and they define TRT as, basically they're only quote unquote taking 500 milligrams of testosterone, and they consider that TRT. And no, that's not TRT. I mean, maybe relative to taking 2 grams a week
Yeah, no
compared
doubt.
to half a gram a week, that is considered a significantly lower dosage. But first, I wanted to kind of discuss. Let's define for the average person here. What is the difference between TRT and then now when we kind of cross over to anabolic steroid abuse, because obviously we use testosterone as the base compound typically, obviously, for men in that are prescribed this. So, what are your definitions of what is considered clinical TRT under physician prescribed, medically supervised type of treatment?
100%. So you said itself, there's so many different kind of terms now. You've heard TRT, you've heard of andropause, I've heard of male menopause. These are all kind of synonymous, but what we're all talking about in a sense is testosterone deficiency. Well, what's deficiency? So if you look at, and that's the other thing, it can get a little bit confusing because different labs have different, I guess you say, normals, highs and lows of what's considered to be. But if we go off the American Urology Association's definition, they're looking at somewhere between 300 to 750, 800 nanograms per deciliter, somewhere in between that. That is the amount of testosterone measured at a given time. Based on their algorithm, they want to see or to opt to make sure to if whether or not this measurement is accurate. They typically want it to be a morning test, something before 11 a.m., usually actually even before 10 a.m. And the reason is because that's usually when our testosterone is the highest. To clinically define someone as testosterone deficient, they need to have two measurements of about less than 300 nanograms a deciliter twice at two different times, not the same time of the day, but 2 different days. That means clinical diagnosis. Now, that also should be able to look at the clinical signs of low testosterone. They are multiple. It ranges from fatigue, just general unwell, worsening in terms of energy levels, erectile dysfunction, just loss of muscle. There's a substantial amount of them.
Depression, right? I mean, there's
Depression is a huge one. Mental health is an entire irritability is another one. Now, but this is where the kind of rubber meets the road a little bit. That's the clinical definition. I get a little concerned with that because what I just said, 300 is the cutoff. So theoretically, somebody could be 305, 310 and be normal. But are they normal? What is normal? Well, we just talked about all those clinical signs. So if somebody is presenting at 310, 320, 400, but they're showing all these signs and we have no other clinical reason to say why those are present, well, we may actually have an individual who is still suffering from the effects of low testosterone. So they still should have the opportunity to be optimized.
absolutely. No, I think that's a very good point. So blood work is definitely important, but it's not the end all be all. It's one biomarker of several biomarkers that we're looking at. And in addition to that, the biomarker, the blood biomarker, you want to look at those clinical symptoms. And this is why I think it's important for particularly men. I mean, I say typically you don't see it much in guys in their early 30s, but you start seeing it sometimes with some. Definitely over 40, you start seeing some of this more and more. And in the 50s, 60s, it's definitely more prevalent at that point in time. Um,
100%.
where I do see it and have seen it in younger individuals is those that either one, they have some sort of genetic disorder, obviously, which are some cases, but those that have um, from other type of conditions where maybe they utilize or and abuse anabolic steroids early on in their teenage years or early 20s. They maybe went on a 5-year, 6-year, 7-year stint of heavier use. Then that can actually naturally decrease your testosterone production, sometimes for a long term, even if after doing post therapy type of uh, um, programs, right?
Yep,
A PCT cycle,
that's
they're
it.
not necessarily going to recover and rebound from that if depending on the individual. So you may have, I mean, and actually, I'm a good example of that. So for me, my testosterone levels were fairly low, in my early 30s,
Yeah.
because I had, experimented with some things at a younger age.
100%. This is where the unfortunate reality of our unique subclass of sport or our just who we are in what we do is there's not a lot of long-term trials to show, well, how long would it take for somebody to regain normal physiologic function? How long should the post-cycle therapies be based upon how long you were on? These are things that we don't have double-blind, placebo-controlled international trials to be able to give us a lot of data. So we're kind of having to extrapolate what we've learned from other trials that aren't exactly in this patient population and the anecdotal information we're learning in our own little bubble and try to kind of
Absolutely.
merge them together.
Absolutely. So, to kind of come back to the TRT component. So, um, if for example, I've heard guys in their 20s and early 30s say that I'm on TRT, and my first question is TRT, number one, is a clinical, something that's clinically prescribed to you. So
Right.
if you're not seeing a physician, you're not on TRT. You're
100%.
you're you're taking anabolic steroids at your own whim at that point in time, depending on
Right.
on the dosage, right?
100%.
Um, More than likely, if you're in your 20s or 30s, for the majority of males, probably unlikely that any physician would find it clinically necessary to prescribe testosterone replacement therapy. So for you to be on TRT, just because you're taking, say, 300 milligrams a week of testosterone, which is still a super physiological dose for most individuals,
Yeah.
that's not considered TRT. But
No,
in the gym world, we often hear that is like, oh, what's your quote unquote TRT dose? And it's usually in the neighborhood of like 300 to 500 milligrams a week. Because they're just kind of talking, they titrated their dose down again from a gram to 2 grams a week down to 300 milligrams a week, which in
yeah,
that case it is a much lower dose, but it's still not TRT.
no.
So so
Things that
TRT,
make TRT is what you just said. Number one, was it confirmed what your lab were your levels confirmed actually, or is this more of just like, oh, I just chose to be on, like you said, I was on this, so now what's this? Two, what labs have you done? Have you done total testosterone, free testosterone, sex hormone binding globulin, estradiol? I like to do all four because that gives a true scan. Then finally, and this is the big one that people don't do, did you have follow-on labs to be able to identify if the current dosage is reaching our goal? And if not, has it been adjusted over time? And are you frequently checking the other things? And what I mean by the other things, when we're on TRT, even if we're on super physiologic dose of testosterone, we definitely need to do this. But even on TRT, we need to keep an eye on CBC. We need to keep an eye on hemoglobin and hematocrit because even on TRT, we could see actually an increase in blood viscosity. So that is something that needs to be monitored. So if somebody thinks they're on TRT, but they're not getting it from a doctor, they're not having follow-on labs, they're not monitoring the other things that need to be considered, and they're not if these levels, like for instance, hemoglobin hematocrit begin to rise, and they're not doing the appropriate treatments, such as therapeutic phlebotomy, then you're not on TRT. You're just on anabolic steroids light.
Yeah, absolutely, absolutely. So I think it's very important that those individuals who seek true TRT treatment, and I think there's a lot of men that would benefit from that. Typically, if you're over 40, over 50, I always recommend go get checked out, get your blood work done, but by a physician. And I would say find the right physician because not all physicians are the right fit for this type because they
Correct.
don't necessarily have the training. Some of them, they're just going to look at the blood work and like kind of like you said, it's like, oh, your levels are 400 nanograms per deciliter. You're normal. They're not really going further into the weeds. But when you go further into the weeds, you really need to, you may actually qualify for doing some of these protocols.
And we have to remember too, and doctors are also people. They're human, so there's bias. So there is still some doctors out there. Doesn't mean they're wrong, and doctors are great doctors, but sometimes they're still going off of archaic data.
Yep.
They might think that, oh, it's gonna cause prostate cancer, or it's going to cause you to have a heart attack, or you're gonna have these multitude of conditions that are going to manifest from that. When now the data actually not only has it refuted that, it's actually been quite interesting that a lot of what we thought was the safer way isn't. In fact, the American Urology Association put out a good paper in 2024 talking about how low testosterone, subtherapeutic dose of testosterone actually have increase your risk of cardiovascular mortality and issues. So we were so concerned over the last forever that oh we can't use testosterone, it might cause a heart attack. Ironically, by not paying attention to testosterone, we might have opened up people to the potential of a heart attack.
Absolutely. Yeah, that was a really good paper that really opened up, I think, a lot of people's eyes when you actually see some of these relationships that individuals with the low, because it comes with a lot of things, right? I mean, things like sarcopenia, right?
Yeah.
Increased fat mass. So now your body composition changes significantly. If your energy levels are low, you're probably not going to be so incentivized to go for a walk, to do things that are normally going to keep caloric expenditure that are going to be good for you. So then physical activity levels are going to drop naturally. And then you put all those things together, right? Now you're less active. Maybe once you get into your 40s or 50s, for most people, probably make a little more money than you did when you were in your 20s or your 30s, right? A little more financially stable. So now it's easier to do what? Go on cruises, go on vacation, go out to dinner 3 or 4 days a week, have some nice bottles of wine. So now you combine all of these things together. And then, this is what I love. People say is I'm aging and my metabolism is slow.
Mm,
Well, not really. It's probably your lifestyle's just probably changed. You're actually probably moving a lot less and you're
correct.
probably not really conscientious of what it is that you're consuming. But then now you're leading to things like metabolic syndrome, diabetes or prediabetes. You're going to have a higher body fat percentage, and that's going to lead to potential other health issues over time.
100%. You highlighting something that is so important that the vast majority of patients do not get in this conversation is the importance of lifestyle, the discussion of total daily energy expenditure, and the fact that hormones, while extremely important, are only one part of muscle protein synthesis. And
Right.
without adequate, proper protein intake of essential amino acids and the stimuli for mechanotransduction of physical activity, we're missing the boat. And I tell my patients this a lot is when they ask me about TRT and wants me about hormones, I'm like, I need to understand something. That testosterone is an anabolic hormone. And they're like, yeah, I heard of that. I was like, oh, hold on, hold on. I said anabolic means it's going to grow something. It's going to grow tissue. If we set you up for failure, and I don't talk about your dietary habits, I don't talk about resistance, and you stay sedentary, we're going to grow something. We're going to grow fat. We're going to get slower. We're going to feel terrible. So don't think that this is going to magic bullet. We need to optimize the system to promote the development of the tissue we want and promote the actual goals that we want. So I see a lot of these different clinics, no judgment to them. They exist, but those that are kind of like an assembly line, if you will, come in, blood work, here's your prescription, see you in 3 months, bye. They're missing the boat, and they're not providing enough ample information for the patient to truly benefit from everything by missing the exercise, missing the diet, missing the lifestyle modification.
Absolutely. And actually, something that you said, this brings up a really important point that when you take testosterone within physiological ranges, right, you sometimes see individuals that have, let's say, testosterone levels of 600 milligrams
Milligram
per
per deciliter.
deciliter, right? Which is not necessarily low, right? Or even 500, whatever. but and then they go up to maybe 900 or 1,000. Okay, so they go up a significant amount, right? Maybe 80%, 50%, whatever that number may be. What we find is going from 600 to 900, you don't necessarily see a big increase in strength or body composition if you're kind of still in that range. Going from 300 or 400 up to 900 or 1,000, you're probably going to see some of that. But again, you're still within normal physiological limits. So it's not like you become, people kind of think like, oh, I'm on TRT, I'm going to like become He-Man. Not really. You're going to kind of become like you were when you were in your late teens, early 20s, where you can recover better from your workouts. You know, you have more energy. You're going to be able to pursue some of those things. So I think there's often a misconception that just the testosterone levels alone are going to do that. Now, I'm going to say that only within the normal physiological ranges. Obviously,
Oh,
once we go to super physiological, and there's that study by Bashin et al. I think the 2001 study that looks at dose response relationships, and they in that particular study they have men go hypogonadal, so they kill their testosterone level, and then they put them on different dosages of testosterone. So they put one group, I forget what the dosages were, but it was something like 50 milligrams a week, 125 milligrams a week. One was like 300 milligrams a week, and then the other one was 600 milligrams a week. And then that's where you see that dose response relationship because they had the individuals doing appropriate nutrition, appropriate exercise, and then what we do see is like there's not a big difference between the 50 and the 125 or 150. Those are and their testosterone levels kind of go to at 125, they're within normal physiological limits at that point in time, which is a pretty good testosterone replacement dosage to start individuals on. Typically is about
sure.
100 milligrams, 125 milligrams. It's not a bad starting point for most individuals. And then like you
100%.
said, being the physician, you would then evaluate what those levels are, what the symptoms are, what the other blood will looks like, and then you titrate accordingly. Maybe they need a little more, maybe they need a little less. But most TRT are going to top off at about 200 to 250 milligrams a week. And in this
100%.
particular paper, what we actually see is once they reach about 300 milligrams a week, now you start seeing those super physiological levels of testosterone levels start to come. And of course, once you get to 600 milligrams a week, their levels go up to something like 2,600 milligrams per deciliter, so significantly super physiological levels. And of course, there's a dose response relationship to their strength and their muscle cross sectional area and everything else. So really kind of takes us to that next point where what's the difference between TRT and then now going to the abuse component? So the abuse component, when you see a lot of these, highly competitive, high level bodybuilders, for example, that, I'm not going to say all of them because there are some that are very naturally gifted naturally, but I'm
Oh,
going
for
to
sure.
say a large majority of them are going to be,
At the elite level,
using
for sure.
at the highest level, using some sort of super physiological dosages. So, and this is when we actually see the data of individuals using, I mean, the low end is maybe 600 milligrams a week.
Oh yeah,
And then
yeah.
you're usually seeing, a gram, 2 grams, 2.5 grams a week of different
Mhm.
anabolics. It's not just one. Now there's polypharmacy.
And that's a huge part. I'm glad you brought that up because in the clinical world of TRT, you don't find Anadrol, you don't find Trenbolone, you don't find Dianabol, you don't find these. The prescribed medications are basically just testosterone of different esters. And the big ones that you typically see prescribed is enanthate, cypionate, and undecanoate. Those are the three big ones. Reason being is because that's what the data has, and that's what the FDA has approved. We have enanthate in auto injectors. We have cypionate in, I don't think they have auto injectors yet for that, but it's usually in a draw vial. And then we have undecanoate, which now is oral. So it just depends but to your point, these medications are prescribed at dosages and vial sizes of the 100 to 200 milligram range. And we hardly ever see anybody go far past that. Once you start going into those other areas, once you start getting these other medications, they're not the FDA approved treatment anymore. They're not the TRT anymore. Now you're diving into, like you said, the polypharmacy of enhancement.
Exactly. Yeah, I think that's a really good point that you made, that really the only pharmaceutical grade drugs that you can get today, in back in the 60s and even into the 80s, they were still manufacturing some of these other compounds,
True.
but right now, nandrolone decanoate can still is still, medically prescribed sometimes, and then you have, but mainly testosterones are the ones that are most prescribed, and then you see Anavar, the oral Anavar. That those are the only three that you can actually buy from a pharmacy or a compounded pharmacy that could be medically prescribed. You're not going to see the Anadrol, the Dianabol, the Stanozol, none of those. You're not going to see
No.
any of those things out there. But nevertheless, those are often used in, I mean, trend's the big one, right?
Oh yeah.
I mean, kids now, there's so much misinformation on trend, saying it's a magic drug, quote unquote. But anyhow,
Yeah.
that's what they're trying to put themselves on in very high dosages. So like you said, now we're stacking, two, three, four, five drugs. In fact, a study that I published on regional bodybuilders, we did a survey, and most of them did an average of four drugs. And this is in a regional show preparing for regional competition. And then there's other data on other things, but polypharmacy is very common in the bodybuilding circles, and the dosages are extremely high. So that being said, when you are in super physiological dose, it's important to do it when you're on TRT. Talk about the importance of doing testing and working with your doctor when you're now going to that extreme of the spectrum.
100%. So it's important that we in the clinical world begin to start changing how we communicate about these topics. We typically, when we start seeing patients who are going to commit themselves to a certain lifestyle, but they also wish to do so with the best chances to maintain a healthy life, they instantly get turned off when they enter a place and they say, "No, stop. Everything you're doing, stop." Well, all are they? No one's going to stop. But what we've unfortunately done is created a barrier, a huge barrier. Now they're not going to seek even the most basic of care, and now we've left them to basically fend for themselves. So I say that to start off by saying we in the clinical world need to just be able to say, fine, I see what you're doing. Let's optimize you. Let's do what we can the safest way we can. And it starts off with the basic labs. CBC, like we talked about, starts off right there. Many issues that I've seen in the past of individuals having a cardiac related event or maybe associated issues is secondary to excessive erythrocytosis, excessive amount of blood. There's something called Virchow's triad, which is what we use to describe what can cause clotting in the body. And one of them is a more viscous blood. So what do we do? Okay, well, we know the likelihood is there going to be an increase of that while you're on gear, while you're on your therapy, while you're on your whatever you're on. So at least 12 every 12 weeks, maybe four, maybe 3 to 4 months, get your blood checked. We got to see where we're at. If we're noticing trends, then you incorporate therapeutic phlebotomy into your treatment. Okay, we want to keep your hemoglobin at a certain range. About 15 is at least where we're kind of safe. Okay, so we monitor that. That's one. Is there a potential impact to other organ function? Possibly. So what do? We monitor those, monitor liver, monitor kidneys. Why? Maybe not necessarily just because of the testosterone, but what you mentioned is not all the medications that individuals are taking are FDA approved coming from a pharmacy. We sometimes are getting them from their friend who got it from a friend who got it from probably somebody's freaking garage. So particulates could be present in these things, which could be hepatotoxic. So it's not necessarily the testosterone itself that they think they're taking could be an unknown particulate in there. So we do CMP, complete metabolic panel. Look at the liver function, look at the kidney function, maintain electrolyte balance. Watch all these things every 3 to 4 months, and we monitor that. That at least gives a much better likelihood that the big things are being watched.
Yeah, I think that's great. And I know there's some other components that we see with abuse in particular. So you see, for example, dyslipidemia, right? So you're going to typically
100%.
see an elevation in LDL.
Yeah,
Usually HDL levels start to decrease. So that's another. So a lipid panel is probably one of your other ones that you'd probably throw
100%.
in
In
there,
fact,
right?
you did a presentation when you were talking about SARMs. And you saw the exact same thing. You saw an elevation, a complete disruption in the lipid profile. So
Yes.
a lipid panel is also incredibly important. Why? Because lipids over time are associated to cardiovascular risk. We want obviously to optimize HDLs. We want to optimize a lower LDL and triglyceride and cholesterol. We obviously don't want to bottom somebody out. Cholesterol is a necessary thing.
Right.
But when they're completely out of range for so long, and then finally, one thing we didn't talk about, not saying it's a direct correlation, but typically when individuals are on this, their dietary habit may be a bit skewed, maintaining glucose checks. I'm a big believer that maintaining long-standing control to make sure we're not having any kind of intolerances or resistances to other hormones. So even at a young individual, I at least will get an A1C, at least in a person at the age of 35 and above, at least one time. And if I'm starting to see disruptions, we monitor it a little more closely.
Yeah, I think the A1C is great because it gives you, that average blood glucose levels for the past few months, and also hypertension. That's another thing that can. And
Vitals are
so
extremely
I
important.
think I think it's important to check for that. Of course, you don't do blood work for that, but you should probably invest in getting a sphygmomanometer, blood pressure cuff, and
Mhm.
getting that measured regularly so that you can get things checked out on a regular basis. And if you don't know how to do it, then learn how to do it or go to a clinic where you can do it. And with the cuff, it's also important. A lot of guys are going to be bigger arms,
Yes.
so I think you need to find the right size cuff because otherwise you're going to get the wrong readings. You may actually show a reading of hypertension, but because you have a small cuff, let's say you got 20-inch arms and you're using an average size cuff, that's actually going to throw a wrong reading. So that's important to understand that piece.
We live right now, we're in a very interesting time where remote patient monitoring has, because one could argue a lot to do because of the COVID pandemic, a lot of technology came around to be able to have a pretty accurate reading of these vitals because we were having to do it from a distance. We couldn't see our patients. And what I advocate is for individuals to find a cuff that fits their arm, then they do well. There's a lot of sports companies now, not name dropping because I'm not affiliated, but I'm just experienced with them. Garmin has actually a very good blood pressure cuff, and it's a very wide cuff. Well, what I would always advocate is if you obtain one, take it with you to go when you see your primary provider, whomever you see, and compare the readings and have them do it in the proper way. How do you do a blood pressure correctly? Most people don't do it correctly, not because they're doing it on purpose. They just don't know. You don't check a blood pressure when you're moving around and you just sat down, your legs are crossed and your arms are here. No, it's in order for a true accurate person needs to have been sitting comfortably in a room for about 5 minutes. They gotta just then the blood pressure cuff needs to be put above the elbow, and they got to maintain a neutral position of the arm, and then somebody else needs to check it. And if those readings are done properly, and like you said, proper cuff size, and whatever those numbers are, if done correctly, compared to the one that you have at home when you buy one, if the readings are similar, you can feel like you can trust it. One thing I want to add because it popped in my head of what we do differently in the sports world, especially with somebody on this, is in false negatives or false concerns of labs. You'll see time and time again that individuals who start super physiologic dose of testosterone or just excessive muscle, they will go get a CMP and check renal function, and they will be told that they're showing kidney impairment. Mostly because they're going to look at their labs and they're going to see a creatinine that is elevated and the GFR is tanking and everybody freaks out. Something's wrong. Your kidneys are starting to have problem. Ask for a cystatin C. Why? Because creatinine is directly associated to muscle mass. As your muscle mass rises, you will naturally have more creatinine. More creatinine naturally causes an improperly low GFR. It's all algorithms, all math. But a cystatin C has nothing to do with muscle. So that is an accurate reading when it comes to a person of large muscle and not who's showing signs of inflammation, like from infection or any reason. So that's a really good thing to ask your provider if they're not doing it.
I love it. Yeah, and I think the other reasons you want to see your provider. So now you're getting all your blood work done. You're getting on a regular basis. You're getting monitoring on everything. And then if something's out of whack, at least you're aware. You're not putting your head in the sand pretending like it's not there. And,
Correct.
and one the example that I like to use is the cholesterol. Right, dyslipidemia is very common. It's not going to kill you tomorrow, right? But if you have dyslipidemia now for 15 years, right, 20 years, where you have skewed LDL to HDL ratios, now this is kind of brings us to the next component. What about doing like a cardiac CT score, right? Like a calcium CT
Calcium
score.
core.
You can actually look at that and you can see like what's going on here and what's the likelihood because if that calcium CT score is high, the likelihood of you having some sort of issue down the line is going to be significantly elevated. So,
100%.
yeah, I think, and that's something that your physician can order to kind of help monitor that. And it doesn't necessarily need to be done every year, but maybe every couple of years, every 3 years is something that you can monitor. I mean, some people do advocate to do it at least once a year, but at least get it done and kind of and have some sort of regular checkup to see where you are today versus where you are, in a year from now, 3 years from now, and then you have some sort of uh, way to keep up of what your health is looking like internally. Other things are like your physician may order an echocardiogram, right? And
What I
now
was
you're
going to say,
looking
yeah.
at things like ejection fraction, which is another thing that's important to measure because very commonly, I mean, the the androgen receptor is not just found in muscle, in skeletal muscle. It's found in a lot of other tissues,
Right.
including your heart muscle,
Cardiac
right?
muscle. Yep.
So cardiac hypertrophy is very, very common, and that can lead to potential the cardiomyopathy, which one of those types of cardiomyopathy may be like a decrease ejection fraction component, for example.
Yeah, 100%. And the fact of the matter is, a lot of these tests now are much more readily accessible. They're very cost effective. An echocardiogram is nothing more than an ultrasound, and it's
Right.
wonderful. It's completely non-invasive. It can be done in the comfort of most facilities have easy access to them, and you can do them once a year if you choose to. Calcium score, a little bit more in depth, but not invasive, and it gives you an amazing amount of data. Heck, now even dual energy X-ray absorptiometry machines have actually had additional software put into them to potentially give the same accuracy of calcium scores. So some people, when they go for body composition analysis, actually, two for the price of one, get a calcium score. So it allows
Yes.
them to be able to get that information. There's a slew of data to be able. And then there's something called the ASCVD risk score, which is something that we use to determine the potential likelihood of a cardiac related death and within 10 years. And we use multiple components of a person's age, comorbidities, other lab values. We throw it into an equation and it lets us know, okay, based on your blood pressure, based on your lipids, based upon other disease states and your age, your risk is now increasing. We have to talk about that. And we're not, and we take it away from just the world of the testosterone and we show it it's all about all the components. So if we begin to decrease all these other risks, we decrease the overall risk. So I improve your blood pressure. I improve your glucose control. We monitor your weight. We make sure the body composition. We check the calcium scores. We can do a lot of things instead of just saying, take away the testosterone.
Yeah, no, absolutely. And that brings us to the next point, which is the physician now. So now you have these lab values, you have these other different tests that are being done. They're monitoring your clinical symptoms. So then now, if you actually see some of these things coming out of line, with the help of the physician, they understand what other things you're taking, maybe any other medications that you're taking, if any, but they can also prescribe medications to help now mitigate some of these risks. So, for example, our dyslipidemia. Well, if you've tried different things, well, you can try a statin, right?
There you go.
Hypertension. Well, maybe you can try an ARB blocker like telmisartan, right? So
Yep.
there's a lot of different things that a physician can now prescribe and then give you in the right dosages. And then now they'll also have the expertise to know all of the drugs that you're on and how to manage them accordingly, making sure that you're not having any issues. Because even with telmisartan, for example, that's a commonly prescribed, I'm going to say, first level drug for a lot of drug users. In fact, there's
100%.
there's a whole school of thought that a lot of anabolic steroids should just automatically go on telmisartan. I'm not quite there yet. I would say, always look at blood work, look at where and use it when it's needed. Um,
Exactly.
that being said, telmisartan can sometimes actually hematocrit levels, because it works on that on it's because it is an ARB blocker, can actually
Yep.
maybe your hematocrit levels and your blood cell count isn't quite as elevated, because the telmisartan can actually help moderate some of that. So again, there's a lot of tools in the tool bag that you can use, but working with the doctor can actually help you in choosing the right ones, and then you're not trying to you know, you didn't go to medical school, most people, right? So let the physician do their work and understand pharmacology, understand physiology, and then put it to work for you.
No,
Um,
I mean, and the fact remains is we have so many different tools now. I mean, SGLT2 inhibitors are showing wonderful, like for instance, I have a patient who is on hormone replacement therapy, but they're also have a little bit of a little of insulin resistance. Well, that's not a contraindication. In fact, we've shown evidence that low testosterone worsens insulin resistance and worsens diabetes. So this individual who is actually also on an SGLT2 inhibitor, which has cardiac protection. It actually improves renal function. It's helping with his insulin resistance, and it actually shows improvement in blood pressure. So with one additional medication, we're now treating multiple things and decreasing his overall risk for him to easily continue his testosterone therapy. So, like you are highlighting something so important that there's no benefit for the average individual, for anybody, to go into this kind of world blindly thinking that they're just going to be told to stop. No. Find a physician, a medical practitioner who is open-minded to the data and is understanding your goal, and to say my goal is to feel better, live better, be at the peak of my performance while I'm on this earth. Fantastic. I'm all about that. Then let's make sure that everything else is in line. And if you're a person who just wants to be huge and you just want to be the biggest guy, I would temper that mentality and say, I want you to have your goal, but not at the risk of your health.
right.
Just does not hurt to go check. It does not hurt to go talk to somebody. And if you find out that, hey, you're 265 pounds of cow, but hey, guess what? Your blood pressure has a systolic of 185. We need to talk about that.
Yeah, absolutely. Absolutely. And this is something that I like to, hopefully that some of the younger individuals are listening, because sometimes, when you're 18, 20, 22, you think, I'll deal that when I'm 40, when I'm 50, that's what I think about. But putting your head in the sand is the least responsible thing you can do. So even if you decide to start, at a relatively younger age, to reach bodybuilding goals or performance enhancement goals, take your health seriously, because you only get one body, and you definitely want to take care of that. And putting your head in the sand is not the way to go. At least you want to understand what's going on. And what's funny about some of these things, I've been working with enough people where you really see some inter-individual variability with some individuals, that there are some individuals that a little bit of anabolics makes things go haywire.
Hmm.
And then you see other individuals that can a lot of anabolics and not a lot changes sometimes. So, but you have to figure out where you are and what's working for you, and how things are affecting you. And then this is again where having this data that's available to you is very important, because if you just put your head in the sand for many years, then this is where now where you're 5 years in, 10 years in, 15 years in, now you're going to have some problems, some of them that are irreversible, as some data has shown.
100%. And what you said too is so important is that people will obtain something, Lord knows where they get it sometimes, and they get either insane results, which are outside of what they expected, or they get no results. And sometimes they have to ask themselves, is what I just have in this bottle actually what I think it is, or is it just a bunch of cottonseed oil with nothing in it? That's why it's so important to be able to continue checking your blood, checking these labs, checking this to be able to see and quantify, there's nothing changing. So whatever you're injecting, I don't know what that is, but it's definitely not what we think. And we haven't even really discussed on all the different modes of how we can do this. Intramuscular, subcutaneous, pellets, which I hate, patches, gels, orals. I mean, the list goes on and on. This is a very, very in-depth discussion in terms of what we're doing here. So talking to your medical professional, talking to an expert like yourself, and talking to like-minded individuals in this field with decades of experience only can it help you. Don't feel like you have to just learn what you're learning from the insert social media guru here.
Yeah, no, I agree. I agree. And one thing that you already mentioned this, but I wanted to highlight this piece is a lot of individuals are getting if they're going on gear on their own and it's not medically prescribed, which obviously if you're 25 years old, you're probably not going to get it medically
You're
prescribed,
probably not
right?
getting
Because it's not medically indicated. Um, you're probably going to get it from an underground lab.
it.
And that underground lab, you don't really know what you're getting. So it's really important. There's a lot of impurities, as you stated. You don't know how it's manufactured. It's not overseen in any way, shape, or form. And there are some labs that are good and produce good quality things, but there are some that you don't really know. And there may be some of these impurities. So number one, that could cause infections, or worse, right? It could cause other issues, like you said. Maybe it's hepatotoxic, and you have some issues with your liver because of the compounds that are in there. So it's important to understand that component of the risks that you're taking. And another thing that I like to say is for the young individuals is, be mature enough that you can make these decisions and understand, your health. And it's more than just affording that cycle. You have to actually think about how much is it going to cost for me to see my physician, to get my blood work done, to get all of these other tests done. Because if you're just scraping enough money for that, it's kind of like buying a luxury vehicle, right? And then you got to go change the oil on it, or a tire burst on it, and it's a $500 tire. Well, I only have enough money for the car payment. Well, now you can't ride your car because you have the $500 tire you got to fix, right? So there's a lot
100%.
of other things besides just what you're trying to look at. You gotta really be um, have the financial stability, mental maturity to be able to do the right thing.
Yeah, and I feel like, and I'm not picking on the young folk because God, in that word, that's not us anymore. But I want to stress this when because I remember thinking when I was young too that maybe the older doctors, they don't know anything about this. They don't know about what this like. They have to realize we were around. Okay, we know what how this is done. I remember trend being made through a coffee maker. Okay, we've been around. We know the science. We know the underground. We know what's going on. Honesty and openness is only going to be beneficial. It's only going to protect you. And letting your physician at the same time learn who your physician is.
Yeah.
If it's somebody who does not understand this world, does not understand the science, does not understand what you're doing, find somebody who does. Find
Right.
somebody with the experience. Find somebody who, when you tell them, yeah, I'm not gonna lie, I got these tabs and they say Phenoplex. I started to like, okay, okay, I know what you did. Let's make sure we're gonna do these labs, we're gonna do these tests, and we'll go from there, okay? But it gives you that peace of mind to know you're talking to somebody who's been in the trenches. They understand what's going on versus a person who's like, I have no idea what you're talking about. That's kind of concerning.
Right. And you made a very good point earlier too, that even as healthcare providers, whether you're a nurse, a physician assistant, nurse practitioner, physician, athletic trainer, even strength and conditioning coach, anyone, physical therapist, you're going to be often encountering these individuals, and if you are judging them, you're not doing them a service, right? So I think it's our job to educate without judgment.
Right.
I don't think it's wrong for a physician to say, you should consider these are the risks involved, and you know that, but you put the decision back on the individual. Your job is to inform and educate, and then ultimately treat. Because like you stated earlier, if you have a patient that's on high dosages of anabolics, and they're not going to stop, it's no different than treating a diabetic who's not treating their diabetes.
Correct. 100%. I would never, God dang, I hope I would never see this. See a patient with an A1C of 14 and somebody say, you have an A1C of 14, which for those listening is wildly uncontrolled diabetes, and say, I'm not going to take care of you until you stop all the things you're doing that's making your diabetes high. That makes no sense.
Makes no sense at all.
It's mind shattering. So I instead you say, you'd like to think they'd say, I understand your lifestyle. I think we both can agree it's not helpful how, in terms of your disease state, we're going to work together to try to get you better, knowing full well you're human. You're not going to just stop everything you're doing tomorrow. I want to be able to have you enjoy the things in life that you enjoy, but at a level that's going to bring your this particular issue to a safe level, so we know that you can enjoy your thing, all these things for the long haul. That's my job, and we're going to do it together, and we're going to do it for the long term. No different here.
Love it. Love it. Well, Ed, I think we touched on a lot today. I really appreciate you coming on, and I definitely want to bring you back on. We'll discuss some other topics, a lot of fun stuff, and I think hopefully there's some good people that listen out there and get some good use and some good information out of it. So thank you so much for coming on, and I want to let people know, where can they find you? I know you're on social media, and I know you're starting up on that, and I want to let people know where to find you.
Great question. And to show you how much I'm starting on it, I am going to look at what my name is on that to begin with. So on Instagram, I go by Dr. Davila underscore DO. That's DR, my last name underscore DO. And I've been doing a little bit more on TikTok, and it's the same thing, Dr. Davila. So if you guys have, oh, and there it goes that. If you have any questions, comments, concerns, complaints, anything like that, please feel to reach out. We'd love to hear about it. And it could be maybe a topic you and I could talk about again if there's something that comes up that a lot more people would be beneficial to hear.
Great. And you have your own medical practice, Ed?
I do. So I have a cash-based practice called Precision Health, or based out of San Antonio. And basically our focus is performance medicine. It's a little coin, not necessarily just the person who is already at the peak of their performance trying to achieve like another level. I define performance as the ability for somebody who has difficulty standing to be able to safely and confidently get up from a chair to the ability for somebody to pick up their grandkid, the ability for somebody who couldn't walk on a treadmill to eventually be able to run around a track. That's performance. Performance is what drives us to be able to have the quality of life for the long term. And that's what we focus on.
Great. And then, so obviously, you're taking patients in the San Antonio area?
Yep. So we are virtual primarily to start, but as we continue to grow, we'll have more locations and more to follow.
Great. I love it. I love it. It's great. So, again, I know Ed. I've known him for a couple years. If you're looking for a good doc, I definitely trust him. And thank you so much for coming on and sharing your advice and your knowledge and your expertise.
Thank you for your platform. You're doing amazing stuff for so many people. They're going to benefit a lot from everything you're putting out, sir.
All righty.